Hey guys, here we go again. Let's go over chapter 23. I'll probably have to do it in smaller increments because I'm just getting used to this YouTube thing. But let me show you around my home office. It's exactly how you remember my other office. Very messy and cluttered. Ta-da. Ta-da. Here we go. Skip over to the other computer. Ta-da. Look at all that mess. Just the way you remember it, right? Have to excuse my hair. Remember, I work from home now, so I can look any way I want to. All right, let me put this somewhere. And we're going to start on chapter 23, Care of Patients with Brain Disorders. A lot of what you guys will be doing in practice, you're going to see lots of different kinds of seizures. You're going to see, seizures can happen with people with epilepsy. You might see seizures in pediatrics with children with febrile illnesses. You might see seizures after brain accidents. You're going to see seizures again on this test. I know there has to be seizures on this test. You might even see types of seizures on your NCLEX. But I would definitely pay attention to the types and what makes them different from each other. Your book says the etiology of seizures can be symptomatic of a large number of disorders, and we talked about those. It could be lots of different things, including even drugs or toxicity to some kind of chemical. Anything that can cause disruption in the firing of your neurons of your brain can cause a seizure. It's almost like when, I doubt any of you guys remember VHS tapes, but back when we had VHS tapes or cassette tapes and it would get messed up, or maybe even a record and it skips and skips and skips, or something gets jammed. It's kind of what a seizure is. Your brain just gets discombobulated and cannot function the way it normally does, and what you get are a lot of spastic movements, people passing out, at least not being able to talk to you, depends on what kind of seizure it is. Your brain just cannot function the way it normally does. Highlighted parts in your book, if you'll remember, are always important. So if they're bold, it's usually something for you to highlight again. And this one says seizures also can occur anytime the brain is deprived of oxygen. So you have to think about your respiratory patients a little bit too. People who, drowning accidents, respiratory failures, anytime, and think about what oxygen does for your brain. All right. So if I could have a stroke from deprivation of oxygen, which we'll talk about probably somewhere in this chapter, if I can have a stroke from deprivation of oxygen, then I definitely can have a seizure. Anything that disrupts the firing of my neurons in the way that they normally fire can cause seizure-like activity, okay, or seizures, right? Seizure-like activity would be something else that I don't know if it's covered in here or not, but we'll see. All right, patho. First, we're going to talk about epilepsy. Epilepsy is a chronic disturbance of the nervous system characterized by various types of recurrent seizures that are the result of abnormal electrical activity. Again, it's just that firing, all right? Your brain wants to fire correctly. When I'm sitting here right now, even when I'm not doing anything, my brain is firing, all right? My neurons are firing. Electrical impulses are traveling down a neuronal path, and they're making me do things, all right? So I'm consciously moving my arms. When I have an epileptic activity or if I have a seizure, I'll probably still see movements, but they're erratic because my neurons are not firing correctly, all right? So in epilepsy, these are people who get diagnosed. These are people who typically have seizures all their life. It may be triggered by things in their life, maybe sometimes adolescents will get it when they're going through puberty. It just really depends, okay? This says that epilepsy is characterized by spontaneous recurrent seizures. Just like I just said, you're going to see them more than once. These people need medicated. They're probably going to be on medication for the majority of their life to control the seizures. All right. Some unknown stimulus causes cell membranes to depolarize. The depolarization of neurons cause abnormal sensory or motor activity and may cause unconsciousness. Again, a lot of these people who have epilepsy are going to be like people that you normally think of when you see a seizure. All right, a lot of it, those weird jerky movements, and sometimes they just kind of go out of it. You might see foaming at the mouth. It just kind of really depends. The neurons involved have a low threshold for excitation. The excitation spreads to surrounding cells, spreading the activity's small area throughout the brain. Seizures are classified as either partial or generalized. Each seizure lasts a few seconds or a few minutes, and the abnormal electrical activity generated can be captured by an EEG. We talked about an EEG last time. An EEG is anything that's going to, flash bright lights at you, and I don't know if you guys watched the videos before, but an EEG, if you'll go watch the Kanye West video, All the Lights, there's even a little blurb at the first of it. It says, if you have epilepsy, don't watch this. And it'll give you a pretty good idea about what an EEG looks like. So go watch that video. All right. So if I need to know, I need to see if I can recreate something that causes a seizure to check for epilepsy. You guys remember when Christian had his seizure, they did an EEG on him. The only problem was, I don't want to do an EEG if they've been recently medicated with a barbiturate or an opioid, anything that's going to change the way I'm firing for a little while. If you guys remember talking about opioids and barbiturates back in the day, we said, you know, they make you really sleepy, they make you drowsy, you can't operate machinery, you know, all that stuff. If I'm taking opioids or barbiturates or anything that controls anything up here heavily, then I need to have that EEG scheduled far away from that medication, all right, or I won't get real results. All right, a partial seizure. Partial seizures are further divided into 3 subgroups. Simple partial, in which consciousness is not impaired. Put that in your memory. Simple partial. That's about as low as you go. You don't lose consciousness, but you definitely can tell something's going on. But there are other motor, sensory, and autonomic psychological symptoms. Complex partial seizures, in which there is some impairment of consciousness with or without automatisms, which is repetitive automatic actions such as lip smacking, all right, and partial seizures that become generalized as the seizure continues, all right. So your least amount of one, I don't lose consciousness. When I've got my complex partial, remember that word partial means that I'm still not losing it, all right, but I've got more motor problems than I do with the simple, and then I'll go all the way up until I've got my partial seizures, okay. So I would think that a good way for you guys to think about this is to look them up on YouTube and watch. If I was in class right now with you, we'd be watching a partial seizure. We'd be watching a simple partial. We'd be watching all 3 types of them. So go to YouTube, watch and look at those. If you can put some kind of picture in your head about what they look like, it'll come more easily. Partial seizures are also called simple or focal seizures and result from abnormal localized cortical discharge. Partial seizures with complex symptomology may also call temporal lobe seizure because they usually originate in the temporal lobe. Excuse me. Because they usually originate in the temporal lobe. Partial seizures can be unilateral, which means one side with involvement on one side of the brain and activity only on one side of the body. Okay. And we'll talk about this later too. A lot of times when I have anything involved on one side of the brain, the opposite side of my body will be affected. Okay? So when it comes to partial seizures, kind of think of partial as not the most severe. All right? Not say that they're not pretty debilitating, but when I think of a partial seizure, I automatically think of the person that just kind of goes staring blankly out into nowhere. There's a really good one that's been going around Facebook. She never loses consciousness, and when she comes out of the seizure, she's awake, but very, 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 very confused. Just look them up so you can see what they look like. Going on to generalized. Generalized seizures are bilaterally symmetric, and they affect both sides of the body equally. Go ahead and highlight that. That's important. And do not have a local onset. That is, they do not typically begin in one part of the body. Generalized seizures makes me think of it generally gets my whole body. Okay? Generalized seizures include absence, mild clonic, tonic, clonic, and atonic seizure, and infantile spasms. And I think somewhere along in this book, we actually talk about tonic, clonic, and all that stuff. As a matter of fact, I will find it. But just know right now that generalized, I can be doing a various amount of things. And those are going to be the ones that you see people on the floor shaking, smashing about. All right. Generalized seizures are characterized by bilateral synchronous electrical discharges in the brain. So if I had a partial seizure, I'd probably see it on one side. Okay? Don't make fun of me for doing that. I'd see it on one side. What if I had a generalized seizure? I would have it probably all over my whole body. The patient usually quickly loses consciousness, lasting for a few seconds up to a few minutes. And they may have an aura. This one is a huge one. All right? You're gonna hear this a million times. An aura could be 30 minutes before they have a seizure, they smell an unusual smell, and it's usually the same thing every time. Or they hear a ringing in their ears. There's something that precedes those seizures that is common to them. All right? And you usually see that with generalized. Now, there's been a big debate about auras in the last few years. Be careful what you read on journals. For the purposes of this book right now, we're sticking with that some people still have auras, okay? It says the manifestations of epilepsy depend on the area of the brain where the abnormal firing occurs. Absence or petit mal seizures last only a few seconds. That's already in bold. I want you to highlight it again. The onset is sudden with no aura or warning and no post-ictal symptoms, okay? So I need you to highlight that whole thing because it's under generalized seizures because it affects the whole body. But what I'm saying is here that it's very sudden, all right? It's not like the other generalized seizures where I might have an aura. A petit mal, I don't. It just occurs. It just happens. No warning signs. And when I say there's no post-ictal symptoms, that means when I come out of it, I may be a little groggy and tired because I just used my whole body, but I'm not going to be horribly confused. I'm not going to think that I don't know who I am, which is, I'll tell you that people who have these generalized seizures and they're having maybe grand mal seizures, not petit mal, but grand mal, then they're coming out of these seizures. They don't know where they are. They're very confused. They don't know they can't even use their arms right. All right, but you're not going to see that in petit mal. All right, so absence or petit mal, remember that one. Seizures of this type tend to affect children between 5 and 12. Go ahead and circle that because that's definitely something that you want to piece together with the petit mal. And I kind of always think about that in my head as they're petite people, so they have petit mal seizures. There's usually a twitching around the eyes or the mouth, and the person maintains standing or sitting and appears to have just had more than a lapse of attention or a moment of absent-mindedness. If you don't look up any other of the seizures, please watch a video on what a petit mal looks like. Some of you, actually a lot of you probably want to go work in peds after you've gotten out of your clinicals, and a lot of you have children. It's just something that's very strange, and sometimes people don't even know it for a while. They just think their kids just kind of like zoned off for a minute. And then you get to looking closer, and while they're zoned off, you see a little twitch. Okay, and then they're just out of it, and it's just gone. There's a girl on YouTube that I used to show videos of that she knew her triggers. She knew what would cause her to have a seizure, and for the video, she would do it so she could show people what it looked like. I don't remember who she is, but go find it. It's amazing to watch. All right, with tonic convulsions, there is a continued contraction of all muscles and the head becomes rigid. Remember tonic. Okay, when we were back in fundamentals, tonic is a tight. So with my tonic convulsions, there is the squeezing of the muscles. It's like those muscles are all contracted with a tonic convulsion. Grand mal or tonic-clonic seizures usually begin with bilateral jerks of the extremities or a focal seizure activity. There is a loss of consciousness with both tonic and clonic convulsions. That means I'll have the tonic, the squeezing of the muscle, but I'll also have the jerking. All right? So tonic, I've got that tight, rigid. Tonic, clonic, I've got tight, rigid, and movement. Okay? Loss of consciousness. The patient may be incontinent during the attack, and there's danger of biting the tongue. Okay? In the postictal, after the seizure phase, the person is confused and drowsy. So that's what we were talking about earlier. Don't know where they are. Very, very sleepy. Very confused. All right? Those are interesting to watch as well. And make sure you remember the word postictal. Atonic or akinetic seizures are characterized by loss of body muscle tone that results in nodding of the head, weakness of the knees, or total collapse or falling. Now, write it down somewhere. Write tonic. Write tonic-clonic. Write atonic. If I put A in front of any word, it means none. Loss. Okay? So if I've got tonic, think the fundamentals. Tonic is tight. All right? Tonic-clonic is tight but movement. And then atonic is loss of function, okay? Let's see here. It says these are often called drop attacks. The person usually remains conscious during the attack. And the third major group is unclassified seizures. Oh, you'll see this on many, if you go to work ER, you'll see lots of unclassified seizures because they don't get to see them. Somebody comes in with a seizure, the doctor didn't see it, so it's usually an unclassified seizure. Simply means that not enough data has been obtained to determine which kind of seizure it is. The fourth designation, status epilepticus, can be life-threatening. Simply means that not enough data, is for prolonged partial or generalized seizure without recovery between attacks. Status epilepticus is in a grave condition. I expect people, even though you're watching a seizure and it looks like it's taking forever, it usually only takes a minute or two. I'm losing some oxygen. Hey, I don't breathe right when this is going on. So, I'm getting some, all right, but I'm worried about, I've already got something going on with the brain. I'm worried about losing oxygen, all right? And I am worried about them biting their tongue off. Honestly, though, in a regular situation, there's not much I can do about them biting their tongue. It's not like you're going to have a bite plate in your pocket. When we used to have people admitted to the hospital, we always put a bite plate at the head of the bed, and we always put an oral airway taped to the head of the bed. Now, you may go to hospitals that still do that, and I'll always tell you that putting an oral airway at the head of the bed for somebody who has epilepsy is a priority. If they have a seizure that lasts and lasts and lasts, getting an oral airway in could be the difference between oxygenation of the brain and none. Bite plates, you don't see those a lot anymore. A bite plate was simply something that we would try to get between the teeth so they didn't bite their tongue or they didn't crack their teeth. And I can't even fathom that right now. But we found out a lot of times when we try to get a bite plate in, we do a lot of damage or they bite our fingers off. So definitely an airway. Okay, airway. Remember your ABCs: airway, breathing, circulation. If I don't have an airway, I can't breathe. If I can't breathe, I have no circulation. Right? All right. I am going to let's finish seizures and see if I can upload that. The diagnosis of epilepsy is based on the history and actual signs and symptoms. Definitely going to do an EEG so I can try to recreate the seizure, okay? Especially for those people who come into the emergency room, the doctor couldn't see the seizure. I need to look at it. I'm going to do an EEG to see if I can recreate it so I can classify the seizure itself. Also going to do an MRI. When it comes to MRIs and CAT scans, it's like I take a knife and slice right through your brain so I can see in the middle. I need to see if there's tumors or infarcts. Remember, an infarct is a place of pretty much dead cells, all right? Lack of oxygen causes an infarct. That's a big one. If I've had a stroke, that's obviously some sort of infarct. So anyway, if I'm having seizures, what I should know when I come into the emergency room with new seizures is that I should know that they're going to do an EEG and they're going to do a CAT scan, preferably an MRI. Okay? I should know this. Honestly, in a lot of situations, I'll probably see a lumbar puncture as well. They're going to draw that spinal fluid out to make sure you don't have some kind of bacterial infection of the brain. Okay? Treatment. When the cause of seizures is known in cases of high fever or drug toxicity, medical treatment is aimed at controlling whatever the problem is. Obviously, and usually you're going to see children have the febrile seizures and not adults, but it can happen. But if I've got a kid that's having febrile seizures, get rid of the fever, okay? If it means that's going to be antibiotics to get rid of the bacteria and antipyretics to get rid of the fever itself. If it's really bad, I've heard of kids being packed in ice before, so that's going to be a last resort, but it could get there. If it's because of a drug overdose, then I need to do something about getting that drug out of the system, all right? So if it's people that are classified as epileptic, they're going to be on some sort of seizure medication, anti-epileptic. You'll probably hit that pretty soon in Pharm. On your page 526, we're not going to go over them, really, but I'm going to tell you some very, very common ones you're going to see in the field when it comes to seizures, so check mark them. Tegretol, Valium, because Valium is something I can use in emergencies. It's a barbiturate. I can put it in an IV if they're at the hospital, and if they're in the middle of a seizure, that barbiturate will calm them down because I am calming down all this firing of the brain, all right? It's firing weird. If I give you a barb, it's going to slow it down, okay? So if I can give you that, we're awesome. Also, Neurontin. Lamictal is a huge one, all right? And when you get to your Pharm class on Lamictal, please pay attention. There are lots of weird side effects of Lamictal. Keppra is going to be a big one. Dilantin is a huge one. Below, for absence, akinetic, and myoclonic seizures, Clonopin and Depakote are absolutely, absolutely huge. We see valpuric acid quite a bit as well, so go ahead and circle that one. Those are just names to know, probably your most common. You will see them again, and when we get to pharm, we'll talk about them again. Surgical treatment, I could go in, and I couldn't go in, but the surgeon could go in and try to remove pieces of the brain that don't fire right. There's some little implants they can put in the brain now that will cause, I guess it kind of does like trying to reset the firing. You don't see that a lot though, unfortunately. You're going to see a whole lot of medications. Make sure that you're looking at this clinical cue. It's talking about IV phenytoin, which is Dilantin. Definitely need to know that one, just for life in general. Nursing management, always pay attention to those focused assessments, because you're going to see all of that again. Those are what you have to do. Yes, you need to know what goes on inside these things, but down to the cellular level, not so much. What you're going to do about it is what's important. So when I'm assessing somebody with seizures, if I don't get the right data or collect the amount of data that I need, we cannot make a diagnosis. So it's important for you to pay attention to all these focused assessments boxes, okay? Again, we're going to be looking at neuro checks. We're really looking at lethargy and confusion. And we're looking at headaches, speech impairment, all those things going back to that neuro check again. So pay attention to that one. I'm not going to focus on the nursing diagnoses because you can read on those. Going over to the next page, you're going to see highlighted in black again, it says never try to pry open the patient's mouth or insert something into it if the jaw is clamped down. That comes to the bite plate. If I'm going to hurt them and I'm going to hurt myself. Now, if they're having a seizure and they have an oar and it's coming on, maybe use a bite plate. You just don't see them a lot anymore. I guess it really depends on the situation. What I do want to do is these things. The head should be turned to the side if possible to prevent aspiration of secretions. Seizures, they tend to foam at the mouth and sometimes they vomit. So if I can roll them to their side without hurting them, I need to do so. If I cannot roll them to their side, at least turn their head to the side. If I have oxygen, put it on them. If I see somebody out in the road with one, obviously I don't have oxygen, but if I have it, stick it on them because I'm losing oxygen anyway when I'm having a seizure. So let's push a little bit more up in there. Let's see here. Check oxygen saturation with a pulse oximetry if I'm in the hospital. Check a glucose level because I could be having a seizure because my blood glucose is 10. All right, so check that. Look for injuries. Obviously, if I'm in the hospital, I'm going to know if they've had an injury. If they've gotten up and fallen and hit their head and they're having a seizure, I can pretty much guarantee that I know what's caused it. All right, just read through that. Safety alert, patient who's receiving phenytoin is receiving tube feedings. Stop the tube feedings for 2 hours. I don't know how much you'll need to know about that, but it is a good tidbit to learn for life, especially if you go on to being a neuro nurse. They have some really awesome step-down units and neuro ICUs at the big hospitals in Tennessee, so it just depends. Patient teaching is always going to be a huge one. I don't know if you guys have noticed about the kinds of tests that you get and what you see on the NCLEX, but this world is all about preventative medicine. So when it comes to teaching, I need to make sure that I am teaching my patients how to go home and take care of themselves and things to look for. So please, we won't go over it. Just read the patients with epilepsy teaching. All right? I'm going to stop the video and come back with a TIA. Oh, I'm not going to have a TIA. We're going to come back and talk about a TIA.